Welcome everyone to the Annenberg Conversations on Gender, our second conversation for this spring semester that's focusing on gender conceptions of preconception health. My name is Dr. Andy Tan. I am Associate Professor here at the Annenberg School and Director of the Health Communication Equity Lab. I'm really pleased to have our alum, Dr. Susan Mello, from the Communications Studies Department at Northeastern University to join us on today's conversations on gender. And just a quick reminder to the attendees, we welcome all of your questions during this conversation, and feel free to include them in the Q&A function within your Zoom functionality that you can see at the bottom of your window today, and I will try to get through as many questions as possible towards the end of this session. Dr. Mello is an associate professor, as I mentioned, at the Communications Studies Department at Northeastern University. Her research is focusing on the nature and the effects of exposure to risk information in the media, with a specific focus on COVID-19, electronic cigarettes, as well as prenatal and pediatric health. Her work has been published in the Journal of Health Communication, Maternal and Child Health Journal, Risk Analysis, Health Education and Behavior, and Nicotine and Tobacco Research, among other flagship journals in communication and public health. She's affiliated with Northeastern's Social Science Environmental Health Research Institute, as well as being an Annenberg alum and former research fellow with the Wharton Risk Management and Decision Processes Center, the US Fulbright Program, and the Harvard T.H. Chan School of Public Health. She lives in Boston with her two adorable small children, ages 5 and 3, and she's also a dear friend of mine. Please join me in welcoming Dr. Sue Mello. Today, Dr. Mello is joining us to discuss issues of gender in health communication with a specific focus on preconception health. So to get us started, Dr. Mello, what exactly is preconception health?
Well, first, I just want to thank you and Annenberg for the invitation today. It's really exciting to be engaging with the Penn community again. So preconception health actually refers to the health of women and men during their reproductive years, which is roughly between the ages of 18 and 44, or when they're likely to have a child. It focuses on taking steps before an actual pregnancy to safeguard the health of a potential future baby and also of the mother and father. So for women, this actually includes healthy lifestyle behaviors such as stopping the use of tobacco and alcohol, reaching and maintaining a healthy weight, and reducing exposure to toxic substances in plastics or in the environment. It's also advised to learn your family health history, to go through some genetic screening, to get your recommended vaccines, and also to take folic acid, which is a pretty easy behavior. For men, this also includes maintaining similar healthy lifestyle behaviors in order to reduce the chances of infertility and also to improve the health of your sperm. And it also includes screening and treating for STDs. Today, birth outcomes in the United States are worse than in many developed countries. Babies are born frequently prematurely, particularly during the pandemic, and have low birth weights. And since half of all pregnancies in the US are actually unplanned, surprise, it's critical to get everybody on board as early as possible. Fortunately, these recommendations are beneficial for men and women, whether they're planning on having a baby or not.
Thanks for getting us all on the same page and defining this concept of preconception health and its importance for both women and men. Since the focus of our conversation series is on gender, what do we know about the expectations for women and men during their reproductive years? And I'm assuming they are vastly different, and your research can speak to that.
Yes, expectations of men and women are very different before, during, and after a pregnancy. Prior work points to 3 primary reasons why society tends to hold women more accountable than men specifically for preconception health. So first, and this is the most obvious one, but men and women have inherently different biological connections to childbearing, right? Women physically carry and bear the children, and their bodies are thus positioned, unfortunately, at the forefront of gendered biopolitics of responsibility for a child's health and welfare. Second, there's a general lack of awareness of men's contributions to preconception health. The science is relatively newer and is often excluded. Studies have shown from parent education programs, from preconception health websites, which could explain why men typically tend to score lower on tests of preconception health awareness and knowledge than women. So men just have less awareness and understanding of their contributions to preconception health, and women are less aware of it as well, of how men play a role. And lastly, why there may be this imbalance or differences in expectations is that pre-existing gender stereotypes and different socially constructed roles and identities for men and women are also perpetuated by, and we love to blame, mass media, right? And communication about preconception health. This includes public service announcements and different campaigns that have been run over the years. For instance, in 2013, the Centers for Disease Control and Prevention launched a national campaign called Show Your Love. And at the time, it was targeting women specifically and promoting healthy behaviors prior to conception, exactly what we would hope for. But it was criticized for conflating womanhood with motherhood and also for promoting pronatalism, right? So it was showing your love toward the baby. And people were worried that this was a practice of encouraging people to have kids when in fact, many people choose not to. And it was doing this by framing a woman's life as devoted and almost exclusively to one's future babies. So the campaign, fortunately, has since expanded its target population. So if you were to Google it now and find their website, beyond just heterosexual women, and now promotes the well-being to help, quote, young adults achieve their life goals rather than focusing on children, on women specifically. Another example of mass media and communication perpetuating these socially constructed identities was again from the CDC. They took heat back in 2016 when they issued a press release that was reporting that most women who stop using birth control and want to get pregnant as soon as possible, this was an observational study that was done, were actually failing to stop drinking alcohol. Okay, this is actual data, fine. That they were reporting on to raise awareness of the issue. The problem was that the CDC's final recommendation to healthcare providers was that the healthcare providers' advice to all sexually active women not using birth control should be to not drink alcohol at all. And as you can imagine, this sparked serious backlash over women's rights and bodily autonomy and freedom to choose. And then one other example that really piqued my interest in this topic, and we had discussions about this back in 2015, was the Zika virus epidemic and research examining public health communication campaigns during that in Brazil, where they were hard hit by Zika. Those campaigns were criticized for placing an inordinate burden on women to prevent both pregnancy and Zika infection. The research that was done found that the campaigns excluded men's participation in contraception management, as if women were the only ones who were responsible for this, and also for Zika prevention, and that reinforced biased gender roles. They were framing responsibility entirely as a women's health issue. And there were some news articles in US papers that were criticizing this in the United States as well. But in Brazil, this is particularly problematic as a traditionally patriarchal society where women have limited power and access to resources. And these campaigns further burdened women by prescribing health behaviors that were honestly unrealistic and beyond their control at the time.
Thank you for sharing those really important examples of how health campaign designers might be put in a position to be more thoughtful and intentional in implementing various health promotion campaigns without necessarily overburdening women in adopting those behaviors specifically and leading to sort of further unintended consequences in patriarchal kinds of principles that are influencing relationships between men and women in those societies. Thank you for highlighting those. And those are really recent examples. So
It's still
2017
happening.
wasn't very far away. So speaking about your original motivations for working in this area of research, what interested you to pursue answering questions with regards to preconception health and the role of gender?
Sure. Well, it actually started about 10 years ago. And I blame my sister-in-law. She got pregnant with one of the first of her 3 kids. And I observed a dramatic shift. And she's a pharmacist, so she's very engaged in health, but in her health and information seeking behaviors. And we were young at the time, around 25, 26. And that transition to parenthood, regardless of when you have your first child, but it triggers an incredibly high need for orientation because, like they say, kids unfortunately don't come with instructions. So we have to look for them. And like my sister-in-law, many moms start looking everywhere they can for guidance. I started to observe this more and more with my friends. And as I was digging into the literature, and publishers know this, they target moms with free magazines. Once you start registering for your baby shower, you'll get emails and start subscribing to blogs, newsletters. So there's lots of information out there. And at the time when this was happening, many of the news headlines were actually about unhealthy exposures to environmental toxins. So my history when I came to Annenberg was in environmental health. And this was one of the most vulnerable populations because that window during pregnancy and early childhood is when environmental exposures matter most. And as I was working with Dr. Hornick, my dissertation advisor, he said, we need to get to the people who are getting the most exposure to this information. We know that that was his critical concept. And it turned out to be women. So those environmental toxins that moms were worried about were BPA in baby bottles, formaldehyde in Johnson & Johnson's baby shampoo. Poor Johnson & Johnson just can't catch a break year over year, some bad press. But as I watched my sister-in-law frantically registering for these products and, nesting, as they call it, I wanted to know more about the role that health communication was playing in that transition. So with that, my dissertation was born. And during that project, I performed a content analysis of environmental health information in parenting magazines and websites, which are targeting mostly moms. And I discovered that they attribute responsibility for protecting children's health most frequently, and perhaps not surprisingly, to parents, over and above government agencies like the EPA or the CDC or the FDA and manufacturers like Johnson & Johnson. So they were putting the onus on parents to prevent exposures and to resolve any health issues that kids might be having. And since new and expecting mothers are known to be very active health information seekers, I suspected that exposure to this content and these types of frames would be related to their own beliefs, that they would be internalizing this responsibility. And it turned out it was. I fielded an online survey to over 800 moms and confirmed that hypothesis. The results that were published in the Journal of Health Communication showed that exposure to parenting magazines and websites was positively related to perceived responsibility among moms. So the more that they reported coming across this content, the more personal responsibility they felt for going out and buying these baby bottles and that type of shampoo and reducing exposure to rice, which has arsenic, with a disclaimer that the survey was cross-sectional, but the findings were super interesting and confirmed my suspicions about the responsibility that moms were adopting because of the exposure that they were getting from the media.
Got it. Thank you so much for sharing this motivation for pursuing this line of research that's really important and yielding new information that will help us figure out what is most effective in terms of communication and where the influences are coming from.
Yeah, our inspiration typically is drawn from crazy observations in our own personal lives. I found from talking to fellow colleagues.
So far, your work has focused on mothers. What about fathers?
Oh, that's correct. So I started presenting that work at conferences like NCA and ICA and APHA. And, there'd be the men, the dads in the audience during the Q&A period that would raise their hand and be like, hey, what about the dads? They were often expressing disappointment over having been excluded in the surveys. And I started feeling guilty. I was like, well, the research says that this is what women are doing, and the magazines seem to be targeting women. And it turns out that this oversight happens a lot in research on parenting and preconception health. Pre-existing gender biases have actually led to these gaps in research. And I started to discover several calls in the literature for more gender inclusive research that sampled men. So we answered them. We ended up fielding another online survey to 600 women and men. And this shifted. It was around that period where the alcohol recommendations were coming out and Zika virus. So we shifted from the prenatal and pediatric period earlier to preconception health. And decided to ask specifically about gender stereotypes, since this was coming up more again in personal conversations that we were having with people about our findings. And in 2020, we completed a thematic analysis of open-ended responses to survey questions that was later published in the Journal of Health Communication. And we had some surprising takeaways and some things that I wasn't necessarily expecting. First, we found that women seemed caught in this complex transitional phase. So in their responses, on one hand, they were trying to combat stereotypes and support empowerment and choice for women collectively. So we asked them, should women be doing these things to improve their preconception health and to help the health of a future child? And when they were asked in that collective frame, they were saying, whoa. There's a lot of pressure that's put on women already. But when they were asked about their own personal responsibility for protecting their future child's health, they started to engage in traditional self-stereotyping. They started to talk about it being their duty as a mother to protect the child. So while they were empowering choice for other women or women in general, they were still holding on to these traditional stereotypes. Our female respondents believed that PCH recommendations place unrealistic demands on women collectively, but they still held themselves personally to these extraordinarily high moral and cultural standards of what's known as intensive mothering. And intensive mothering by definition is child-centered. It's very labor intensive, and it places what they refer to as the sacred child's needs above the mother's. So on the one hand, women were empathetic and supported a collective fight against traditional female stereotypes. But on the other hand, when thinking about themselves and their personal responsibilities as future moms, they reverted to very conventional gendered expectations. So I wasn't expecting that. I was happy and disappointed at the same time. Happy to see that we're moving in a direction of empowerment and support for women, but sad to see that we were still sort of hanging on to those expectations for ourselves internally. And we argue in our paper that, and we're here to talk about health communication, that researchers need to explore this tension further. From a practical perspective, we need to know what happens when we address women collectively versus when we address them directly. There's, does this nuance matter? We teach our students in persuasion classes about trying to engage our audience in systematic processing and using these cues by saying, you should do this, but what happens when we do that in this context? So more specifically, we recommended that future studies should test whether these attribution of responsibility frames that speak to women collectively could possibly be provoking reactance in the context of preconception health, right? Because when we talked about women collectively or asked women their thoughts, they were saying, no, you're really burdening women and shouldn't be doing that. And this is what we observed anecdotally in the wake of Zika and the CDC's guidance on alcohol. And I think what we also recommended was that we need to test whether addressing women directly, again, by using those systematic processing cues, like you should eat healthy for you and your future baby, may be good at getting their attention, but does this do better at promoting message acceptance and behavior change? Or could it also be sparking reactance? We just don't have enough data on that. I think it's something that we need to explore. And it's a really delicate balance because we still want to encourage women to adopt these behaviors. But what we need to avoid is perpetuating these unhealthy gender stereotypes and gender roles.
Got it. And I bet well, this is still an open empirical question, whether there could be a generational difference as well in terms of women's expectations more generally for their roles in preconception health and for themselves, comparing younger moms versus those from different generations. That's
Absolutely.
important to study. What were the results for men, and how did they perceive preconception health responsibility for men in general or for themselves individually compared with your participants who are women?
Sure. Well, first, men and women both were uncertain. They reported being uncertain about men's preconception health and the connection that it had to children's outcomes, children's health outcomes. So again, there's this lack of awareness and knowledge, which confirms what prior literature was saying. Some of my favorite quotes were, guys don't know what they're doing, or how do we know that we're having any contribution to this? There's some really, comical responses from the men that I enjoyed. You can look for them in our paper. I made sure to include them. Couple this uncertainty with a history of media reports positioning male infertility as being threatened by outside forces outside of their control. And you have a recipe for demotivating men to be personally proactive, right? So we don't know what to do. If we hear anything about low sperm counts or infertility, it's really because of some external force that's out of our control. How do we expect men to be proactive? And what was interesting is what we found in a separate analysis of this data set. We had some quantitative measures that we analyzed as well. These results were published in Maternal and Child Health. Beliefs that women should engage in PCH were higher than beliefs about men's obligations, again, confirming what other research has found. That said, men's perceived responsibility was positively correlated with their intentions. So meaning that when they felt more responsible for protecting the health of a future child, they intended to engage more in these preconception health behaviors. So health communicators need to adopt a persuasive approach to motivate men. And the silver lining might be in the results regarding gender stereotypes. So gender stereotypes, we're looking for them in these open-ended responses, and they were more commonly expressed in relation to men. Yet they reflected both traditional and more contemporary male roles in preparing for being a parent. Male and female respondents often perceived men as what is known in the literature as maternal helpers, right? So they're there to support women as the primary caretaker, and what they call women as the maternal gatekeeper. The woman is responsible for allowing the men to engage or not engage, and the men are there just to support. So that was more of traditional reflection. But the men, more likely than the women, were more likely to reference contemporary male gender roles as dutiful dads and fathers. So they wanted to play a more proactive role in preconception health behavior and creating a healthy environment for their future children and keeping their health in good shape moving forward. And this supports research into the lived experiences of men transitioning to fatherhood today. So I think, as you were mentioning, there are these generational differences, and we're seeing those sort of play out between men and women as well. And in terms of the implications for health communication, I think researchers should test the relative effects of appealing to or priming these different identities in persuasive messages that are specifically targeting men. Scholars and practitioners now advocate now for less gender neutral campaigns and more for what are referred to as these gender transformative approaches that challenge restrictive definitions of masculinity, right? So challenging that maternal helper idea and fostering more gender equity in parenting. Men can and should play an active role in planning for and raising a family. We know biologically and socially, their contributions matter tremendously. So I think there's great opportunity here for both health communication practitioners and researchers to move us forward.
Perfect. And thank you for outlining those summaries of your key findings from those two papers. And it seems like there's definitely a lot of room for exploring the effectiveness of determining whether values-based kinds of message appeals would need to be designed and tested among men and women separately or individually in order to promote preconception health behaviors in an effective way that doesn't lead to unintended gender biases and problems. On that note, are there any promising gender neutral or gender transformative communication frameworks, strategies, or examples of campaigns that have been implemented in other health contexts, not necessarily in preconception health, to inform your research on applying these strategies for your work?
Yes, absolutely. So first, Lorraine Greaves, who's a medical sociologist at the University of British Columbia, and her colleagues published an excellent book on gender transformative approaches to health promotion, which I highly recommend. In it, they categorize health promotion programs by the degree to which they address gender inequities, using what they refer to as the gender integration continuum. And this is something I plan to use moving forward in my own content analytic work. At one end, they argue that we have these gender blind programs, which completely ignore gender norms, roles, and relations, and may therefore reinforce gender-based discrimination, biases, and stereotypes. So that's not good. Move it a little bit forward, we have gender sensitive programs, which may acknowledge norms, relations, and inequities, but don't address them. A more progressive approach would be a gender specific program, which considers women's and men's specific needs, like we were talking about in the findings with our research, and then acts to accommodate those needs to some degree, but not fully, right? So they're acknowledging that there are differences in specific gender-related either behaviors or beliefs or stereotypes that need to be addressed, and then coming up with some approaches to that. But finally, and I think what the gold standard here is, particularly when there are unhelpful or unhealthy gender stereotypes that are coming into play, is we have these gender transformative approaches. And these directly address the causes of gender inequity and include ways or recommendations to transform those harmful norms and relations. And there are actually quite a few examples of these gender transformative approaches from global contexts. A systematic review that was recently published by The Lancet, actually last year, showed that of the 60 programs that they evaluated that were targeting gender inequity to improve children's health. So again, this is kind of in the ballpark of my own research. Half of those programs were situated in sub-Saharan Africa, which I thought was really interesting. So that's an area where there's a robust literature on these types of gender transformative programs. Of note, most of those programs focused on reproductive and sexual health. And none of the programs, and this is of all 60, so there were some from the US, some from Asia. There were no programs that exclusively targeted gender minorities or LGBTQ populations. So this is an area of research that's really lacking and required moving forward. Just as an example, this is kind of speaking to where they're being implemented. So how are they implemented? One example of a successful gender transformative approach that I really thought was great was the One Man Can Fatherhood program, which was launched back in 2006 in South Africa by an NGO and was eventually sponsored by the UN and used for refugees globally. But it works with men and boys of all ages and is rooted in the belief that all men can become advocates for gender equality and active participants in children's lives, which I love as a mom, as well as, and this is specific to South Africa, but in the prevention of HIV and AIDS. And unfortunately, this is not specific to South Africa, but in the prevention of domestic violence, which we've seen an uptick in during COVID-19 in the United States. The program has found that patriarchy comes at a high cost for men. It's compromised mental and physical health, right? Placing pressure on men to be the breadwinners in the household. That leads to superficial friendships because of lack of emotional expression and limited intimacy because of the gender biases between men and women. So what they argue is that recognizing these costs of patriarchy right, and maintaining that gender imbalance. And also the love and solidarity that many men feel for women in their lives can and does motivate them to work for gender transformation. So they were focusing specifically on priming those beliefs and communicating and making men aware of those costs. So the program has observed many changes in beliefs related to parenting and serves as an excellent example of how gender transformative programming should increasingly view fathers as a critical point of intervention to improve the health and well-being of children, families, and of the men themselves. So this was a long-term program. Men were engaged and boys were engaged in school programs. So it was a large intervention, but one that I think serves as a great example of something that we could adopt even more frequently in the United States when we're targeting men specifically.
Excellent examples. Thank you, Sue, for sharing those recent systematic reviews and work from UBC, Sub-Saharan Africa, and elsewhere. So most recently, you have extended your work to explore how the CDC and WHO are communicating well or not so well about COVID-19 on Instagram. Tell us about this innovative project.
Sure. Well, like many other moms, I spent a lot of time on Instagram and women. And I'm happy to say that the CDC and WHO are actually doing a pretty good job communicating on Instagram about COVID-19. But I'm collaborating with Elizabeth Glowacki, who is a colleague here at Northeastern's Buffet College of Health Sciences. And last year, we harvested posts from the two agencies' Instagram accounts during the first year of the pandemic. And we hired and trained 2 student coders to content analyze all COVID-related visuals and captions, looking for a variety of health communication features that are traditionally considered important, including fear appeal, so perceived susceptibility and severity, gain and loss framing that's used in the messaging, what behavioral recommendations were being made, whether it was preventative or care recommendations related to COVID-19, if any of the people in the videos or their posts were modeling those behaviors. When I think back to Bandura, and then also cues to action, among many other different factors in the content.
Got it. And how are you connecting this new data that you're collecting and analyzing to your prior work or your recent work in gender, health, and parenting?
So in the next phase of the project, while I'm on sabbatical this spring, which is very exciting, I'll be examining how both of the organizations are communicating to parents and specifically to pregnant women about the risks of COVID-19, such as preterm birth, as well as the benefits of behaviors to prevent COVID-19, particularly vaccination. We have a few key objectives for this phase of the content analysis. So first, we want to know how often men versus women are framed as responsible for protecting and or vaccinating kids. We're also curious whether these agencies are leveraging gender blind, gender specific, or gender transformative approaches. Just from a scan of the 2 accounts, this is again anecdotal and not confirmed in the data analysis yet, but I was pleasantly surprised, particularly with the CDC, at how I saw many fathers or male adults pictured with children, and I saw women who were framed or depicted as being the healthcare professionals who were advising the children or the parents related to COVID-19. So sort of breaking the traditional gender roles, right? It wasn't the woman who was calling the male doctor to seek advice about, or the mom calling the male doctor to seek advice about vaccination and COVID-19. So I think we're going to have some interesting findings from this work. For many young women and moms, Instagram is the preferred social media platform. And during the pandemic, we've seen a huge uptick in its use for seeking health information. Since we started tracking them back in January of 2020, both the CDC and the World Health Organization have become much more active. They post more frequently and often multiple times a day. And there's a mix in there of other, consistent health topics that we have to address. But a majority of the content obviously is related to COVID-19. So there's a vast amount of information available there. And for whatever reason, studies of Instagram are very limited compared to Facebook and Twitter. And perhaps it's because of concerns related to mis and disinformation swirling on those platforms. Instagram doesn't have those private groups, right, where you can start conspiracy theories or have those crazy conversations. But both of the agencies have huge audiences on Instagram, totaling close to 15 million followers. So I think it's a really robust repository of health communication that's happening, and I'm excited to see what we find moving forward.
Same here. I'll be excited to read some of your new work emerging from this analysis. If you were to scan the WHO and CDC Instagram accounts today, it seems evident that they are intensely focusing on the COVID-19 vaccination campaign. What does your research or the literature tell us about how gender roles factor into vaccination decisions among parents?
Yeah, so we know from research in clinical psychology that women have a greater vulnerability to anxiety disorders. And this can be partly understood by examining gender differences in biological influences and also in socialization. We're often just more worried about health risks than men are. And that's a long literature. We see this in research on risk perception. So what are some of the explanations, at least for pregnant women, which is a group that's particularly vulnerable to COVID-19? We've seen that beliefs about vaccine-induced harm to the fetus have been negatively influencing uptake. So if you're pregnant, you're worried. I mean, women are worried about the cheese that they eat when they're pregnant, right? And now you're going to give them this vaccine, which is why controlling and combating mis and disinformation on social media is of critical importance for this particular group, right? Because we know that vaccines are actually safe for pregnant women, these particular vaccines for COVID-19, and reduce the risk of complications from getting the virus, which again have been documented. And studies have shown, one other thing that I thought was interesting to note is that studies have shown that pregnant women with school-aged children have actually exhibited a slightly higher rate of COVID-19 vaccine acceptance. And this is something I've seen in my own work. So back to my dissertation is that there's something about having more kids that makes moms more resilient, more seasoned, less anxious, I don't know, maybe more distracted by having more children. But it's something that's important to take into consideration when we're targeting these populations is to understand who may be more hesitant or less likely to accept and how we need to be talking to them. We also know from systematic reviews that the odds of receiving vaccines during pregnancy are often 10 to 12 times higher when a healthcare provider recommends them, which is a good reminder that targeted campaigns and social media also aren't always the answer, right? It's that interaction that you have with your healthcare provider that can really make an important difference, which is why I was having conversations, gosh, this was, I guess, December 2020, with employers who were starting to think about their own vaccination campaigns to their employees. And they were asking whether the CDC was rolling out, a national campaign. And I said at the time, they weren't planning on it, that they were really taking sort of a business to business approach and that they were reaching out to healthcare providers specifically and not to the general public to talk to providers about how to talk to people. So I think that that's a really important thing for us to remember as health comm researchers and practitioners is that these healthcare providers really matter.
Absolutely. And we know from prior research in other health contexts as well that women tend to be the healthcare decision maker among families, even for themselves, for their children, and even for their spouses or partners and parents. So they're sort of the go-to person in making important healthcare decisions. So it seems logical to try to reach healthcare providers and provide training for them to be able to speak with those decision makers. What was surprising last year was that the vaccination rates against COVID were significantly lower for men, despite women expressing greater hesitancy at the outset of the vaccine rollout. Do you have any speculations or some inkling what might be going on?
Yeah, so there was a lot of conversation and debate at the time when these numbers started to come out because we would have expected lower vaccination rates among these anxious and hesitant women, women who were pregnant, right? And there were a few hypothesized explanations, many that tied into gender differences, which is why I thought it would be interesting to talk about this here. One simple explanation is early access to the vaccine, which was afforded by the fact that most of the people who were over 65, a majority of them are women. And that also that women occupy more caretaking professions like childcare, teachers, healthcare workers, which again, there's gender biases ingrained in that systematically. Women, as you just said, are also more accustomed to seeking out healthcare for themselves and their families. So they may have been the ones who were going, to make these appointments. On the flip side, for the men, some of the concerns were that it could be, and this is something that we focus on in health communication more broadly, is that these traditional hegemonic, this masculinity may also be to blame for why men were not vaccinated at the same rate as women. Men who conform true traditional masculine norms as being self-reliant, physically tough, emotionally stoic have been found to be less likely to trust science and also show less empathy toward others who are more vulnerable to COVID-19, which can very easily get in the way of preventative behaviors like mask wearing and vaccination, right? So it's to protect us, but also to protect others. So there is some concern that some of these traditional male stereotypes may be leading to these gender differences in vaccination, and something that we need to take into consideration in communicating with men.
Okay, thank you for sharing that. I think this is a perfect segue for our Q&A session with our attendees. And let me just scan through a few questions that are being contributed at this point. Let's start with the first one. This is a question from Julia. It's remarkable to me as a mom in the US, how much of our education and experience of pregnancy and preparing for parenthood is through consumption. And Julia would like to hear from you what you think about the role and responsibilities of brands, retailers, and private sectors, essentially in health communication about parenthood, preconception health.
Yeah, it's an excellent question, Julia. Thank you for bringing that up. So as a fellow mom, when we go into Target, right, we're picking up products off the shelves and seeing BPA free or, phthalate free for the shampoos or whatever products and lotions that we're buying for our kids. And this is coming from the manufacturers. And this is in the wake of news reports showing that these chemicals, right, research that came out 5, 10, 15 years ago, showing that they were harmful for our children, that they could be leading to early onset of puberty, cancers down the road. So they reacted, and we hope that what they're doing, that they're taking corporate responsibility. But some of the substitutes that these companies have found for the chemicals that they're removing from these products, we just don't have data on them. We don't necessarily know that they're safer options. So it's really hard. And the recommendation that I have for fellow moms is everything in moderation, right? There are so many potential harms in our environment. And they're trying to capitalize on our fears in some way by marketing to us all of these free and healthy and green products. But there are a lot of environmental barriers, social and economic barriers to buying these products. Organic food's more expensive. These types of products are more expensive. Making these choices, choosing to hand wash versus dishwash your kids' plastic silverware, whatever it is, right? It all comes at a cost, and mostly to moms. So there's a burden that comes with becoming more aware and knowledgeable of these risks that we need to take into consideration when we're communicating with moms. So hopefully the corporate marketing is in our favor. I just have kind of I'm a little bit more skeptical and hesitant to believe that everything that they're trying to sell us right now is really safe for our kids.
And I share that concern with you as well. This is really kind of crazy to be entrusting such an important role of health promotion to companies that have a profit motive in selling stuff, right?
Mm, yeah. So another recommendation that relates back to my dissertation is that it's really important to get your information from a variety of sources. So I used to voraciously read the parenting magazines that were sent for free, right? When I subscribed to, when I went to go get my maternity clothes, or I went to my prenatal visits and they were laying out on the table for me to read. Those magazines and those websites tend to be linked to these corporate entities like Johnson and Johnson or Honest Company, right? So you're getting, and the frames that I found in those magazines is they're putting the responsibility on parents. So just make sure you're balancing your consumption of information with general news, right? Go to the New York Times, read the Washington Post, get your information from other places, other reputable, credible places, the CDC, the EPA, so that it doesn't feel like the onus is all on you in reading those types of sources.
So I want to keep the sort of focus on parents, on fathers as well. So what are some sources of information that fathers can rely on in terms of preconception health or fatherhood or parenting?
Yeah, that's a really great question. They are much farther and fewer in between than what we can find for women, for moms. I have seen, I still get Parents Magazine. I had to had to collate them all together for my dissertation, but I'm now on the mailing list and get them. And I'm seeing more dads on the cover. So if I were to do another content analysis, I think I would see more targeting toward dads, inclusivity of dads, at least, gender transformative approach in those magazines and those outlets. Whether it's because the moms are then handing it to the dads to read, or they're, absorbing the information and passing it on to them. So that's one option. The CDC also has great resources on their website for men, for preconception health and for fatherhood. So I think relying on our public health agencies for that information is another good source. Although, content analysis over the last 5 years have shown that they're still limited in the types of information that they're providing to dads, but hopefully over time we'll start to amass more resources for them as well.
Sounds good. This is a question from Bob. To what extent are the claims about men and women's perceptions about preconception, particularly the contrast between generalized empowerment and specific self-responsibility, how are these findings generalizable across social classes, people in different marital situations or non-marital contexts?
That's an excellent question. And I actually, before this talk, was curious. I was like, so I'm recently separated from the father of my children. And now he's playing a much more active role in parenting our 2 kids, which is awesome. But I was like, I wonder how many men are single fathers in the United States versus women. And recently we saw the passing of Bob Saget, who was featured back in the 90s as one of the single dads, right, who was raising his 3 children alone. And content analyses back in the day showed that in the 90s, a lot of the popular shows on television were portraying single dads with live-in help, which was completely unrealistic of what the actual numbers were in the United States. So getting back to Bob's question, only 16% of households or single parent households are led by men versus women. So there's still many fewer men who are single dads. So when you think about how these results are generalizable across the marital, non-marital context and in social classes, there's still an inordinate burden on single moms in terms of raising and taking care of their children. Those differences don't necessarily translate across races either the same. So that's mostly for white populations, but there's also differences. I guess the difference is a little bit less in Hispanic and Black populations. So all of that is to say that I think it's really important to take into consideration if you're talking to or targeting lower SES populations, that you need to take these differences in gender stereotypes into consideration, which is why I think a lot of the work that we're seeing coming out of the international context is from sub-Saharan Africa, where these gender differences are very deeply embedded in their culture. is that they're really fighting an uphill battle there. So they've addressed this very strongly and more intensely than we have in the United States, but it doesn't mean that we don't need to do it.
Thank you for addressing that. I am struck by your description of Lorraine Grief's work with the gender integration continuum and how you described that there's a huge gap in terms of the systematic review that you presented in the Lancet article, where there is a gap of programs or research focusing on gender minorities or LGBTQ populations. Can you speak in terms of how the framework, the gender integration continuum, might be applicable for research around preconception beliefs and behaviors and attitudes among LGBTQ plus populations, and also non-traditional families, including same-sex families and so on?
Yeah, absolutely. So as you mentioned, this area is a growing field of research, but the data out there is still very limited for these populations. A lot of what I've seen is mostly qualitative, where they're interviewing healthcare providers about their experiences interacting with these populations, and specifically transgender men who are seeking preconception and prenatal and perinatal care. So coming in during or after a pregnancy for help. And what they're finding in these settings is that transgender men are reporting feeling invisible in these very highly gendered environments, right? There's a sea of pregnant women around, and that they feel very isolated. And healthcare providers, on the other hand, are reporting that they just need more training. It feels very akin to when I was researching environmental health risks back, 10 years ago, which was the healthcare providers like, we just don't know yet how to deal with this. We don't have the information. We're stretched for time. And what I'm seeing in the research is that they're wanting more printed materials, right? And they want more training on how to use proper pronouns and to target this specific population. So if we come back to the framework, they really want gender specific programs. We're not trying to do any gender transformation here. It's really that we want not only gender sensitive programs, but also gender specific, where we're taking the needs and considerations of these specific populations into account. So that's an area that's, I think, rich for research and practical application of what we find moving forward.
Thank you so much. So I think we are close to the hour. Would you have maybe one or two lessons learned or key takeaways that you'd like our attendees to take away from today's conversation?
I'm always a hopeful person. I'm a glass half full.
Okay.
Than glass half empty. So every time I read these studies, like, yes, there are still a lot of inequities that we need to address. But I think as health communication researchers and practitioners, we have a lot of opportunity here. So if we keep focusing on those vulnerable populations, being aware of their needs and using everything that we have in our, toolkit for qualitative and quantitative research, I think that we can really make a difference here. And I've started to see changes in environmental health. And from that research, learning how to address preconception health, which is at the time a novel issue. And now we've got COVID-19 and vaccination, and then we'll have these, transgender and LGBTQ. I think we're making progress, slow but sure.
Awesome. Thank you so much, Sue, for joining us today in our second conversation in the series on Annenberg Conversations on Gender. And we look forward to having you visit us again in Philadelphia at some point.
Thank you so much.
With that, I would like to thank our organizers for putting this together, Louisa, Rich, Phil, and others in the communications and IT department for arranging this series and putting this together. Thank you so much. And thank you to all the attendees for your questions today.